At this time, I would like to welcome Richard Nevins, independent consultant, who's going to be our moderator for the healthcare business session. Welcome, Richard.
Good morning. How's everybody doing today? I want to welcome everybody to the first symposium, the healthcare panel, and we hope in 2021 is a little bit better news than what we heard in 2020. I'm going to let each of our panelists introduce themselves and tell a little bit about what they do, and we'll make sure that everybody is off their mute button so that we can hear you. Jared, you want to start?
Certainly. Thank you, Richard. And obviously, thanks to the West Houston Outlook Summit for putting this on. This was our first time as last year. It's a great event. I think there's a lot of good information sharing here and network opportunities. So I really appreciate Amerant and those of you putting this on. Thank you, of course, Richard. It's always good to work with you anytime I can. I'm Jared Hamilton. I'm the Human Resources Director for Calvetti Ferguson. We are a mid-market public accounting firm located in downtown Houston, but we do have offices in Fort Worth, Dallas, and San Antonio. I've been with Calvetti Ferguson for about a year and a half now with the human resources team. Prior to that was at a midstream pipeline company located in Kentucky, running HR for there. So I get to be with the end users. I get to hear the celebrations of insurance and medical care and utilization and not so fun celebrations of it. So I get to hear it at the ground level. So I love working with those people, coaching them and teaching them through what's out there when it comes to healthcare and their options and how they can best utilize those. So it's a privilege to be here as always.
Thank you, Jared. Yvette?
Hi, good morning, everyone. My name is Yvette Shaw. I am the Senior Vice President at Texas Children's Hospital for our community hospitals. I have responsibility for our Katy campus, and I also have responsibility for our Woodlands campus. I also have the privilege of working on our entrance into Austin. We're getting ready to build a hospital there and open in 2024, so excited about that. So I pretty much have anything outside of the 610 loop, with the exception of our primary care clinics that are actually under our Texas Children's Pediatrics. I have been in healthcare for over 25 years, worked at Texas Children's for about 10 years, and then had a little bit of a hiatus, about 12 years, worked across the country at other systems, helping my husband pursue his career. And we came back here about 6 years ago and rejoined Texas Children's. And so it's really exciting. Just when you think you have learned a lot about healthcare and you know all types of things about healthcare, you throw in a pandemic and you get to learn all kinds of new things. Certainly in the last year has been a complete learning experience for all of us. A lot of challenges, different challenges that we perhaps did not face previously. I know that I speak for my colleagues across the entire medical center and across all of healthcare. It's been certainly challenging, but a lot of good learning as well. Happy to be here, and thank you for to the Chambers for inviting me and having me. Looking forward to it.
Thank you, Yvette. What about Catherine?
Hi, I'm here. Hey, everyone. Thank you for inviting me, Richard. I'm excited to be here. Thank you to the Chamber of Commerce for still putting this on. My name is Catherine Graves, and I'm VP of Business Development with Evolution Healthcare. We are a healthcare plan management firm, kind of working with brokers like Richard to best transition groups from a fully insured type arrangement to a self-funded arrangement. We bring it all together with a just add water approach, whether it's the PPO network, the pharmacy benefit management, wellness, telemedicine, risk management, all the cost containment strategies that I know everyone wants to hear about, all to help, better make decisions for employers today in terms of their specific company needs. So excited to be here, and thank you guys for having me.
Thank you, Catherine. And Leslie.
Hi, my name is Leslie Weisberg. I'm the Market Chief Medical Officer for Blue Cross Blue Shield of Texas. I've been in Texas for 30 years now. I did my training at UT Southwestern in Parkland and was in private practice for a number of years as an allergist, immunologist, and internist. Moved over to Blue Cross about 8 years ago and have held a variety of positions, including implementation of our exchange products. So when the Affordable Care Act went live, and now I'm the Market Chief Medical Officer with numerous responsibilities, including managing our clinical operations team, working with our government relations team, as well as sales and account management, as well as leading our quality healthcare initiatives here in Texas. So glad to be here. Thank you, Richard, for including me again. I remember last year, this was a very good panel, very informative. So again, thank you for including me.
Thank you, Leslie, and thank you all to the panel, and thank you all for the people who are watching this via technology. And if you do have any questions that you want to ask, be sure and go on Whova and ask those questions, and we'll try and get them to the panel. Obviously, the hot topic of the day is COVID-19. I've read a lot of stuff on the internet, so we know it's true. And so, you know, there's a new strain of COVID. Hey, there's a vaccine coming out. Are we going to be protected? Is this going to be the godsend that we all were hoping? And I'll kind of turn it over to Leslie and Yvette to kind of give on the medical side of things.
Sure, I can go ahead and start, and then Yvette, if you want to, please feel free
Certainly.
to.
You have the MD behind your name. I can talk about how we're handling things. Go ahead.
All right. So yes, with regards to the new strain, there's been a lot in the news and in the literature recently about strains originating in England as well as in South Africa. And now they've been identified, the strain from England, at least here within the United States. It's not uncommon to have mutation of viruses. You know, they do that as their way to continue to survive. In this case, what the mutation allows is for increased transmissibility. So it's, you know, easier to be transmitted from one individual to another. That being said, it appears that the vaccine remains to be protective against these new variants. They have looked at that. They've taken blood from individuals who have had these new variants and used the vaccine to see if it was still viable, and it is. So at this point, I think that the vaccine is, you know, a great option. It's, you know, the best option we have to containing the pandemic. But again, the fact that there are these mutant or these variants, I should say, is something that typically occurs with viruses, but fortunately the vaccine still appears to be effective in protecting against them.
I had the pleasure of serving on a panel for discussion with our employees that are still on the fence about getting the vaccine, you know, and really talking with our experts that were there. And it really, it's exactly what Dr. Weisberg just said, is that there are mutations, but the what some of the findings that we're having or that we're seeing with it is that it's not as severe as the COVID-19 with the different strains. And certainly the vaccine is the best protection. I had the experience, and I did have to consult our experts. I had COVID in November and really asked, well, do I get the vaccine? Because that's one of the questions that a lot of people have, is if I've had the vaccine, if I've had COVID, do I need the vaccine? And the answer is yes. You're never going to get the same protection with whatever antibodies you developed from having COVID. So that's one of the communications that we continue to tell everyone, because that is a belief that people have, is I've had it, I don't need to get it. But it certainly is something that would offer more protection.
You know, that's the interesting part, because there are a lot of people who, you know, the conspiracy pops up about, hey, the vaccine is going to be able to turn you into a zombie, or the government's going to be able to track.
I'm going to be blonde. Movement. I'm going to be blonde by the summer.
That's right. And I know for me, even though some people don't believe it, I am under 65. So therefore I cannot get the vaccine yet. But Jared, as an employer, you know, I know a lot of the schools have all these protocols. You still got people, universities are doing things online. You know, from an employer standpoint, how do you develop protocols, and what have you done that has worked that the employees have still appreciated, and you were able to get things done, but also not put people in any danger?
Well, I think first of all, we happen to be an employer that was a little more progressive with the ability to be remote, and with our PTO, our time off system and policies. So we were fortunate enough that on March 16th, we met first thing Monday morning. March 16th was like, D-Day when it came to the world. Sunday night, my managing partner called me, says we need to meet first thing tomorrow morning and discuss this. And by 11:30 Monday morning, we made the decision to basically tell everyone to go home across the board. And we didn't, it wasn't like we missed a beat when it came to productivity early on, because we were already remote capable. Not because we have a work at home arrangements, but the nature of accounting, a lot of it's done remote. So we had those capabilities. We were fortunate to do so. Other companies that did not have that, they probably had a little bit more of a logistical issue. So that was one thing we were able to do is very quickly just let's send everybody home and assess what we have first. And what was interesting is a lot of companies did not do that. They didn't know what to do, right? So they were just kind of frozen, because we all were a little bit, but our executives do a good job making decisions to allow us to think. So that was the first thing we did that we thought was pretty progressive and fast in terms of let's gauge the numbers and let's determine, because the early information that we had with some of our network was that, believe it or not, this was very early in March, is that the cases were going to double and the death rate was going to be, mortality rate was going to be, 4 to 6% or something like that. And so we were getting that not from websites, but from resources in medical community. So you did the math real quick and it looked bad. Send everybody home. Obviously, since then, a lot of information comes back. What we've done, a lot of the firms, we thought about the thermometers and bringing people in, but obviously, if you have asymptomatic cases that can still, still transmit the disease, I understand the thermometers, but we're like, well, if someone comes in with, a sniffle and we're telling them they're okay to come in because they're only 98.6, we're sending that message. So we opted not to do that. But we are in, 4 offices. So in HR is centralized in Houston. So we have to figure out what's logistical and practical across the offices. So, but we've got a PTO system that's purely open. We don't limit it. We don't accrue it. You can take off whenever you need. And that was put in place years ago because there was a pretty bad flu outbreak in our office, and our executives are like, man, we can't have people worried about running out of PTO and they come in sick, so that was a part of that. So we adopted that years ago, and that was probably the best thing that we ever did. Frankly, it was before my time, and I tip my cap, because that was the best thing we could have done, to where nobody feels pressured to come into the office if they've got something that feels like allergies, because what we're finding is people think it's the allergies. Well, it's just my typical allergies, and they come into the office. We used to do that all the time, a year ago. I mean, a little sniffle, you just get a box of Kleenex and go to work. So we're having to really train the workforce, retrain them, even though we had those policies before. Is like, listen, you do not come in unless you are 100% healthy. And our executive partners, they do not want people sick in the office. And in our last firm update, our managing partner says, listen, this is going to go beyond COVID, is you do not come in unless you are healthy. And I think that's all the risk mitigation strategies are good, but if people are coming to the office with symptoms, that's your problem. That is a large problem. And we've had a couple people come in where we had exposure. We didn't have transmission yet at all in the office, but we have to find out that information. And again, it's, well, I thought it was allergies. And so that's something that we've really tried to communicate and encourage people to stay home. When you log into the system, you have to attest whether or not you have signs or symptoms. And if you do, that you're at home, or if you're in the office, you're 100% healthy without signs or symptoms. So every time you log into our system, you are attesting to that. And so, obviously we're in buildings. So, buildings have risk mitigation guidelines for public areas that we follow. reminding people, I think everyone knows that they need to wash their hands. We don't have someone watching people wash their hands, obviously. But at the same time, I do want to say that we're exercising caution with confidentiality as best as possible, because that's the fine line that we have here. That if we announce, because some of our offices are small, we're not going to cross the line of breaching confidentiality of our employees if we know that announcing something would essentially out them as having COVID. That's their decision if they want to tell their coworkers. But there's been some times where communicating to just general public would breach that confidentiality. So that's the battle we have as employers, is when is it too much information that people don't want to be shared about their health. And so that's just a teeter-totter that we're having to deal with. But so far so good. We were again blessed with some of our processes and systems. Our offices are the March 17th, I was measuring the distance between cubes, and they're 8 feet away. So we're like, great, we don't have to rearrange the office space. So we were in good position from the get-go, which was helpful. Other companies probably not so much.
What about on the insurance company side? The big question we always kept getting was, I'm not sure if my employees are working 30 hours a week. Have the insurance companies kind of relaxed a few things, and do we see a point in time when it's going to get back to normal in regards from the insurance standpoint?
So with regards to, Blue Cross Blue Shield of Texas and our larger parent company, HCSC, we have over 24,000 employees throughout our 5 plan states. And in March, all of the employees were deployed to home, which, as you can imagine, was a significant undertaking. What we've noted with the work from home strategy now is that individuals, are as productive, sometimes even more productive, working from home. So we have not noted any difference, in productivity. I can tell you with my own team, I've not noted any difference. If anything, again, people are more productive. Individuals don't like not having to commute. So I think, there have been positives around working from home. I think there's still the element of, being in contact with your coworkers, which I know a lot of individuals do miss, is that, face-to-face contact. So that, and hopefully we'll get to that point in the near future with the wide distribution and uptake of the COVID vaccine. But we have not seen any significant issues with work from home policy or work from home strategy within our company.
Go ahead, Jay.
I just to say a quick note because there are some companies that we've heard of with that. We did start to struggle from a full remote. We started having to bring folks back. Either we started with half teams, and then we're currently in a 3-day a week, more or less staggering. We were starting to see some decline in deliverables. Now, from an accounting perspective, the ability for associates and seniors to get their questions answered in a very quick time frame with managers, just the nature of accounting work, public accounting work, the connectability for those people are just vital. So we were starting to see deliverables and deadlines not being met. And so we had to adjust. We were hearing it from other firms in our group that partners were struggling with some of the staff because they weren't able to connect as much with either seniors or managers or the people that needed to do to, finish preparing a tax return. So we started to struggle a little bit. We had to pivot slightly, but we feel like, we've got a good mix of the remote and in the office, but it was kind of a delicate balance that we had to make that change in June because of the deliverables that, July 15th was coming, whether you liked it or not, and it was going to be there. And they relaxed that deadline once, but rarely will it happen again. So we had to pivot a little bit to some of the in-office to be able to meet our deliverables.
Thank you, Jared. Yvette, on the hospital standpoint, overcrowded, undercrowded?
We're now returning to our pre-COVID levels, but certainly when COVID hit, we are not as remote as a lot of the industries. You just can't be, because we have the direct patient care. But it really gave us the opportunity to explore those areas that could be remote. And so from the very beginning, we do really, really well with hurricanes and any natural disasters, and we go into a mode that is really very impressive to watch. And this is across all of the organizations and healthcare organizations in Houston. We're used to doing this. So we immediately go into a command center mode. Of course, our command centers don't last as long as COVID has lasted. And so we really started looking at protecting, one, our patients, the families, and then our workforce, because we did have the PPE challenges as everybody else. But what's so great about our healthcare community is how much we partner with one another. I mean, we certainly shared PPE when it was needed, at West Campus next door, at Methodist and the Medical Center, St. Luke's, you name it. Everybody comes together saying, okay, you're getting a shipment in, we're going to give you some now. You give us, you kind of pay back and go back and forth. So it's really an amazing healthcare community that we have here in Houston. We're very blessed with that. And so then we also had to deal with the mandates that we were getting from the state. And so as the governor issued mandates to stop elective surgeries, then you say, okay, what is an elective surgery? Well, we're a pediatric hospital and a women's hospital. The OB side of our business has never stopped. Babies were still going to be born and women are still pregnant. It doesn't matter that there's a pandemic or not. And so that piece is handled very differently. How we get PPE and stay safe. Then we look at our COVID positive patients in the very beginning. Do you isolate them all together? Well, if you have patients that are very ill that have to be in the medical center, you almost have to set up locations for each. And then we went into, from the very beginning, we were dealing with, well, pediatric patients aren't as affected, is what we kept, hearing in the news, et cetera, et cetera. But that wasn't true. We were starting to see those patients. And then when we were working with the other systems, our CEO, Mark Wallace, and all of the CEOs across the Texas Medical Center were on calls. I believe they still have those calls every morning at 7:30, just to kind of get the pulse of where everybody was. And at the point that we knew that our partners on the adult side needed to transfer patients, we started setting up protocols for how do we transfer those patients to Texas Children's based on certain acuity levels. And then, of course, you go into, is our staff prepared? We have people that have worked at Texas Children's in the pediatric population for 10, 20 years. Yes, they were trained originally on adults, but they weren't used to it. So how do we get the competencies back up? Well, our partners on the adult side really helped us with that, come back to help us make sure that the competency levels, all the while we're dealing with our staff, our physicians, starting to have exposure. So it was just it's almost a perfect storm. And then you have the psychosocial issues of our employees who are here for very long periods of time. And then it isn't as if home is a safe haven. They're dealing with what's happening at home. Then you start having companies starting to lay people off. So you have those stresses, and really what we started to do was have respite areas where our employees could actually sit and rest and just have some, quiet time, because it was so stressful, and it continues to be. As we start seeing our volumes come back, which we're very happy to see, we're just dealing with all types of other changes. Our telemedicine visits have certainly gone up. It certainly sped a lot of that we really wanted to get to, but we just hadn't. I mean, we did telemedicine before, but certainly not at the levels that we do it now. And the patient and family acceptability of that certainly went up because they were okay not coming. And so it was almost, I think it was the perfect storm to push healthcare in a direction that perhaps we knew we needed to move, but hadn't quite moved. And so it's been a learning experience for us. The remote workers, do they stay remote? Did we have the IT infrastructure to support the remote? it's been impressive to watch just as a team. And then the tracer piece is one employee affects 10 or 12 because we are so mobile throughout each of our campuses that the tracing piece really became very important. And then, you have the changes with the quarantine piece, the coming back to work, the testing. We started doing drive-through testing for vaccines at all of our campuses and for our employees. So it just was mobilizing. So as you had volumes decrease, you certainly saw your revenues go down, but you needed the screeners, you needed the vaccine testing. So you had people working, it just wasn't in the same realm. So it was a lot of shifting, but we have a great workforce and a great culture that everybody just really steps in and gets things done.
And I'd like to follow up on that about telehealth and some of the, so prior to the onset of the pandemic, the adoption of telehealth by both our providers and our membership was relatively low. And what we've seen since the onset of the pandemic, really a spike in April, which has continued throughout the remainder of the year, is the adoption of telehealth by both members and providers and the increased use. And what we've heard from our membership is, that they like this, that they like telehealth as a way to continue their care for follow-up visits, stable visits, monitoring blood pressure, even diabetic checks. They can share that information with their provider without having to go into the office and have that connection still with their PCP. We've also heard from providers as well who previously had done primarily in-person visits, how they have adopted telehealth and found the importance, of remaining connected with their patients and continuing to follow their care. And at Blue Cross, we definitely had expanded the scope of services that could be provided via telehealth. So we thought that that was very important in supporting our membership and our providers. And we're very happy with the adoption and the continued adoption of the telehealth, telemedicine services. The other thing, as Yvette mentioned, just the hospital capacity and the lack of availability during surges of inpatient beds for individuals, not only with COVID, but other individuals that had health conditions such as chest pain or a heart attack, where they needed care. I know that we worked and continue to have a policy in place to enhance the transfer of members out of acute care to lower levels of care when appropriate, so that facilities like Yvette's facilities and other inpatient acute facilities will have that bed capacity. So I think, the medical community has really come together and, worked with us as well to do what we can in this pandemic to make sure that, our patients, our members, our providers are continuing to get what they need.
Yeah, my heart and my thanks go out to all frontline providers. One thing that Jared had mentioned was that eventually we're all going to have to come back to some type of normalcy. The insurance world has been trying to decide how can we have an idea of controlling healthcare costs. And from what, the new buzzword is reference-based pricing. And I'll turn this question over to Catherine, who can kind of tell us a little bit about that and how it impacts employers today.
Sure, great question, Richard. We love hearing this question. So reference-based pricing really is where, we take provider reimbursements are based on a percentage of what Medicare would typically pay the provider, which can often range from 120 to 175%. So if we look at it this way, a filed cost of a CT scan is $110, Medicare pays $200, and your PPO plan, it's $2,900. You kind of wonder, how does that get paid? Well, today employers have kind of been economically forced to raise deductibles and out-of-pocket maxes to just afford healthcare for their employees. And so the burden is now on them. So that's kind of where reference-based pricing steps in and utilizes a multitude of different factors to calculate what would be considered a fair and reasonable price for each claim. And really only 4% of these claims are ever actually challenged. So that actually means that providers are accepting this, reference-based payments 96% of the time. Now, as a person who sells this type of product, this is a very progressive strategy for employers to take control of their healthcare spend and level the playing field with big insurers. But it's a vehicle that's gaining momentum because of the savings for both employers and employees alike. But it's not for everyone. It's not for every group. It really is a plan of action that I would suggest after moving them into a self-funded type arrangement, unless it is that they're willing to kind of accept the challenges that are going to go on with something as big of a change as this to our healthcare system. So,
the Healthcare Price Transparency Act basically is going to be trying to require insurers to give access to the public on what prices are. And is that going to have an impact on your business, Catherine, or on yours, Leslie?
I don't understand why this hasn't been talked about more in the media, honestly, because this is huge. I think healthcare is kind of the only thing that I can think of that we buy as consumers and have no idea what the price is going to be. So to me, requiring hospitals to disclose what they charge for basic items and services seems obvious because it empowers the consumer first and foremost. And I guess I'll let Leslie speak to that a little bit. I would love to hear her perspective on, how hard the AHA fought against this transparency rule, kind of contesting that it was based on their First Amendment rights to, that this should not happen. And, I'd love to hear from her on that, actually.
So we do support any, the administration and what this act is trying to do in terms of, make healthcare more cost effective and more affordable. So overall, we do support that. The concern remains, though, that this is going to provide individuals with a lot of information to have to sort through when they're looking at facilities or different types of services. And there are some services that potentially are shoppable, such as outpatient imaging, high-tech imaging, but other services are not. So the concern remains that with all this information and all the publishing of data, that one hospital, it may actually drive up costs, because if there is a price differential, one facility may see this and say, well, facility XYZ is getting this much, we need to get this much as well. So we've always tried to promote reference-based pricing. Like I said, we encourage our employee groups to set this, and when members need to have CAT scans, MRIs, like I said, to look for not only the facility with the best, that's the most cost effective, but also is a quality provider. So overall, the intent is good, but Blue Cross Blue Shield of Texas has been doing this now for a long time. We have a number of online tools, such as Provider Finder. We have benefit value advisors. We provide member rewards. So we have already been doing this for at least a decade. And we do think that it is a good idea to promote cost-effective healthcare. The concern is just all the information that will be published online, and will that result in more consumer confusion, as well as having the not what it was supposed to do, but drive up costs instead of driving down costs with this type of transparency.
Right. If I can jump in, I have responsibility for our international services, where price comparison happens every single day, because people from across the globe who come here, we have thousands of patients that come every year to receive care. I think there's a misconception that there isn't price transparency. Anybody can find out what the price is. The understanding part is the difficult part, because when you shop, and we see this with our international patients, and they have a patient who has heart surgery or is going to have heart surgery, they want to compare us to Boston, to CHOP, to Cincinnati, you name it. They're looking at the top 5 children's hospitals across the country. And unless you truly understand the billing mechanisms of what is included in that bundle charge and how they charge, because you can compare us to Boston and we are $100,000 more. Okay, but do they include all the radiology? Do they include the pathology? Do they? And that's something that unfortunately it gets very, very confusing for patients and families. I agree with Leslie. That's the part, is understanding it, and are you comparing apples to apples? I believe it's not going to be as easy as, you know, that the price at Walmart is this, the price at Target is this, the price on Amazon is this. It's just not going to be that easy. And I think it is going to cause more confusion, but we certainly have the resources to sit down with patients and go through those charges. I think the big thing is everybody believes no one's going to like the prices. Well, nobody does like the prices, but it's understanding the prices and what falls through on every single one of them, because our international patients have to pay up front. So they know fully well what that price is. We base our pricing strategy on previous cases, similar cases with similar diagnosis. And I can tell you they are never exactly the same, because we're dealing with patient care. And in the end, even if we collect 100% of our bill charges that we believe is going to happen, it's never the same, because patient care can't be 100% guaranteed or predicted. But price transparency for us, it's not a matter of we don't want to do it. We're perfectly fine. We've always been able to sit down with our financial counselors when patients want to understand, our families want to understand their exact charges. But I think that the confusion it's going to cause for everyday people, because if you look at your own healthcare and, you know, all of us as educated consumers, it gets pretty daunting, because you don't know, are they vending anesthesia services? Are we vending our pathology services from a private group? All of those things come into play that makes it very confusing. So to see that full picture is really difficult, and to be able to compare it, because I believe that in the end, we want to say we've actually selected this based on our research. I think that piece is hard.
I have an end user comment, if that's okay, Richard. Can I have 2 minutes?
Yeah, no, go ahead.
So what I think those are good points. I think we have to strike a delicate balance, because a lot of the times the noise we get, noise is the scientific measurement by which there are problems in medicals. HR gets noise. Explanation of benefits, very difficult. It's already confusing, but the problem is the explanation of benefits comes after the fact, and there's confusion already. And so then we have to explain to them what these mean. And then I recently had one where I didn't understand. My daughter had a cut on her eye and got glue on it. It was $1,800 to seek that care. That is confusion. I mean, 18 for glue. And so I was confused, and I've been in HR. I've seen explanation of benefits. I know all the things, but then you have to call to get an itemized bill, because you don't have access to that first. And so then I had to go through 2 or 3 people to really understand what the breakdown of the cost was. And where the transparency will help is just the realization that a part of that $1,800 was $300, and I can't remember what the itemized name was, but it was for the sterilized tray. It was $300. And I told him, I said, well, I didn't get a tray. All we got was glue. You know, we didn't take a tray. That was just for the tray. Whether that's justified or not, I'm not going to debate that. But I had no idea what $1,800 was for. And so I think there's a balance, which in that I didn't know that was coming either. I mean, there was no signal. It was, daughter got a cut, get it fixed, go home, $1,800 later. I'm already confused at that point. I think we need to figure out a way to, obviously mitigate confusion on the front end, but there needs to be some sort of communication on the front end where patients, when they go in for work, know what's going on. My dentist does it. My dentist says, hey, by the way, if you want to do this, it's about $700. And then that's my choice. I don't have to say, well, what's the $700 for? I can, but I don't have to. It's my choice to either proceed, or say, well, tell me what else, or do I want to go to someplace different? So I think we can strike a balance to where we're not pushing out so many numbers that it's overwhelming, but we're also communicating on the front end instead of some back end high cost surprise billing or balance billing.
I got one more thing to add, if I can, Richard.
Yes.
So, we kind of know that the cost of healthcare is driven by the claims that are actually paid out by insurers to doctors and hospitals for the care given to patients, right? Well, every single element to your healthcare has a price. It's expressly written in a contract between the hospital facility provider and the insurance carrier. So you think about those contract, network negotiations that take place every few years, and having been on the inside, at United Healthcare when that was happening with Methodist, you got to think about that and you go, okay, might it be difficult for the carrier to look like the good guy when, we've got hospitals with names like Methodist or Saint in them? Then you think about, do hospitals and physicians mark up these costs and services because they know that they're mandated to cover certain procedures by the government? And then you think, okay, will insurance companies pay these inflated amounts for fear that they're going to lose this hospital system from the network and therefore lose employer groups altogether? And then you got to go into, how is the insurer going to compensate for all of those high price tags on these, I think inflated cost? I mean, your premiums have been raising, your co-payments are raising, your deductibles are raised year after year. And, you just go, okay, so these are nonprofit hospitals and they can't show a profit, if the insurer overpays. So what are they to do with these extra funds? I mean, I don't know. Are piano players in the lobby of a hospital, are they compensated? Are they, volunteers? It kind of makes you wonder, like, what, it seems all like they're in bed with one another to me. And I think that's the root of the transparency issue. And I would love to go on balance billing next, Richard.
Well, and we're close to running out of time. I mean, the surprise billing is definitely a hot topic people have got. Matter of fact, I got a bill for $1,251, and the date of service was 5/21/15. And so, of course, I sent a letter to the collection agency saying that I've had follow-up surgeries with this provider. Nothing was ever discussed. And it's more than 90 days. And as per your contract, they can't get paid. I mean, I was making up stuff. And at the bottom, I copied my brother, who was a lawyer, trying to add credibility to it. But I mean, that's one thing that's going to be impacting us. And so the next thing is, in 10 words or less, what's the big thing that you have a concern with in 2021? What keeps you up at night? And I'll open it up to Leslie because your mic is open.
So I do want to comment on your surprise billing. So that was passed in December as part of a COVID package, where instead of members being balance billed or individuals being balance billed, that there is the option to go between insurers and providers to arbitration. I do have to say that Senate Bill 1264 in Texas, which was passed in the 2019 legislation and was supported by Blue Cross Blue Shield of Texas. This is already occurring in Texas, where out-of-network providers for certain of our membership are not able to balance bill, and it does go on to arbitration or mediation. The goal for us is to try and take a lot of these out-of-network providers and negotiate with them to bring them into our network so this doesn't occur, because first and foremost, we want to stand with our members in sickness and in health. And part of that does mean that also, making sure that they're not being inappropriately balance billed for these services. So, again, I think to make, the affordability of healthcare and access to healthcare is the most, to me, keeps me up at night. And wanting to make sure that by addressing these issues, that it does, healthcare is more accessible, more affordable for individuals within Texas.
Thank you, Leslie. Jared, what keeps you up at night?
I'm hoping soon, and I don't know if it's 21, because from a workplace perspective, managers, leaders, HR practitioners, when COVID starts to be under control, we've built these habits of asking a lot of questions of employees that typically we would never ask regarding their healthcare, their personal lives, where they were, where they went, who they were around. That is what my concern is one of my managers going to ask too many questions of one of the employees where we get back into a confidentiality thing. So we're going to have to communicate and reinforce when we're out of the public health crisis, like, okay, let's get this thing back. People have a right to their confidential healthcare, because we're in some weird waters asking people certain questions that sometimes I can't believe the information I get, that people share with me, but it's where we're at, and we're going to have to get back to a more place of privacy and confidentiality where it's offered for people.
Catherine or Yvette?
I guess my biggest concern in moving forward is that we stay stagnant, that, with the increase of unemployment and kind of the downturn of employer revenues, that the access to quality benefits will become a bigger challenge. And there needs to be solutions delivering high quality benefits outside of the traditional systems of what we know is in our industry, Buca, Blue, United, Cigna, and Aetna. And I think delivering on easy to purchase, comprehensive, and affordable healthcare must be available to every single group and individual in this country. And I think if we just stay the same course, that definitely scares me.
Thank you. Yvette?
I think from a hospital perspective, and I think this is across all of the medical center and the institutions, is being able to maintain our staffing levels where they need to be with changes. I mean, we're already seeing lots of employees really opt to work part-time or work in areas that aren't quite as demanding. So keeping up with our staffing levels as we continue to see other diseases increase, and being able to have that staff and staff burnout overall is certainly a concern. And we have to keep up with the insatiable demand that we have from our families, and really for the latest and the greatest. And, it's great to talk about how expensive healthcare is, but when it's your parent, your family, your child, the cost doesn't matter. Everybody wants all resources to be in that care, which makes complete sense. But being able to balance that with the cost of healthcare and the professionals that you need, the physicians, the specialists, and the super specialists, because they're not easily available. And we're in a recruitment process continuously to maintain that level of healthcare that we all demand as U.S. citizens. I mean, we're very, very fortunate in this country that we don't have to make those very tough decisions that they make in other countries to stop care because families can't afford it. And that's the situation that we're in on a daily basis. And that certainly keeps me up at night because it affects us all, not just as healthcare workers and employees of healthcare, it's as citizens of the US, because we do have demands and we do have expectations that up until now we've had freely, and accessibility has been, although challenging sometimes, it's certainly, we have the access to the greatest healthcare in the world.
I agree with what everyone is saying, and I would add a way to lower the anxiety that's been created with all the COVID, and also the anxiety on wondering if the Astros will be able to replace Springer this coming season. Yes or no? New president, new Congress, new states. Is this the year that we see a lot of big push, and a yes or no, for a single payer? Jerry?
No.
Catherine?
No way Medicare for all is coming.
Leslie?
No.
Yvette?
No.
So, but do we see it coming in the next 4 years? Yes or no? Jared?
Hope not.
Catherine?
Way too big of a business.
Leslie?
I'll say no.
Yvette?
I think we'll see some changes, but no.
which, in your opinion, is the best way to control healthcare costs? HMO or HSA? Jared.
That's not fair.
And I know you're a proponent of HSAs.
Well, HSAs, you got to you got to give people the options. You can't restrict people with options. But I think we need to talk about appropriateness of care before we start really digging down into costs or method. We need to look at what the appropriateness of the care is.
Catherine?
Yeah, I mean, I agree. I think people are desperate to kind of lower their healthcare cost, and an HSA is good in what it does in terms of the vehicle of savings, but I think it's just a kind of another gimmicky way to mask the underlying issues surrounding transparency within the system. I mean, I don't think that the HMO Kaiser craze is coming back either, especially given all of the combinations of Cigna, Express Scripts, CVS, Aetna. I mean, these acquisitions are obviously safeguards to create more closed networks under the pretenses of consumer savings.
Leslie?
I think both. I think there are advantages and disadvantages to both. So I think that it's just not a one-word answer, but I think both can be beneficial.
And Yvette?
I agree. I think it's a combination. I don't think that there's one fix for all of this. I think it's a combination. I think with FSAs, there's a lot of education that has to be behind that, because there is a lot that the consumer has to do in those programs. And you see those very underutilized because of timing, knowledge, education of them. So I think a combination.
Well,
and I agree. I mean, you know, the one thing I've always told clients was whether you do HMO, whether you do HSAs, whether you do high deductible health plans, it does not do away with the cancers, the prematures. Things are still going to happen. You know, preventive care is still really a good push. And, you know, the interesting part is that when I asked y'all, you know, one word, HSA or HMO, all of y'all decided to add more than one word. So
that's not a fair question, though. It's not a fair question.
It supports the fact that healthcare is complicated. And I want to thank the panel, Jared, Catherine, Leslie, Yvette, and thanks to the chamber, and thanks everyone who has been turning in on this. And if you have any questions for anyone individual, you can go on Whova and ask those questions. And we appreciate it. Everybody stay healthy, keep your masks, and keep the distance, and look forward to seeing y'all come next year. Thank you all again very, very much.
Thank you, Richard.
Thank you.
Thank you so much, guys.
Thank you.
Folks that are wanting to remodel their home, people that maybe want to consolidate some debt, we can actually give customers conditional approval within 48 hours of application. Our clients can close as quick as 14 days. We tell the customers from the very beginning of the process what the rate is. Customers don't have to call a 1-800 number. They have Brenda as their banker that is going to answer all questions or needs even after the loan has been closed.
At Amerant, 24 hours is all it takes to get tailored financing solutions for business equipment. We understand that when it comes to your business, time is of the essence. That's why we provide you with quick solutions for your small business's immediate needs, and will get you pre-approved within minutes. Committed to getting your small business on track in just 24 hours.
Now more than ever, I invite you to join the Houston West Chamber of Commerce. We are in business for business. Please join us.
Now more than ever,
support your local businesses.
now more than ever, increase your visibility.
Have your voice be heard.
Increase your search engine optimization.
Now more than ever, increase your relationships.
Increase your revenue.
Increase your network.
Increase your sales.
Now more than ever, increase your contacts.
Increase your marketing.
Now more than ever, come together as a community.
Now more than ever, join the Houston West Chamber of Commerce so we can continue to support our local businesses.
What did it take for me to beat lymphoma? It took an incorrect diagnosis, a failed stem cell transplant, and one call to MD Anderson Cancer Center to renew my hope. It took the brilliant minds of my oncologists and a groundbreaking clinical trial to defeat my cancer and trailblaze a path to help thousands more.
What will we do in the pursuit of making cancer history? Whatever it takes.
Our goal is to get as many employees and medical staff to get vaccinated as quickly as possible.